Well, good morning, and this is Dr. Richard Foulkes, and I'm really appreciative of you taking the time to come to understand this breakthrough in the treatment that we can apply to corneas that are in need of stiffening, corneas that are too flexible, corneas that are stretching, an unusual situation that can happen in a small number of us called ectasia. So ectasia essentially applies to someone that has a cornea that has begun to stretch. As the cornea stretches, of course, it thins. And thinning and bulging are the two findings you'll have in a patient that has that particular problem. And on my first slide here, my lead-in slide, I'm depicting a picture of what we see when we place a patient in front of a device that allows us to see the corneal curvature on the front surface of the cornea. And in a patient that has ectasia, we'll often see, there's various versions of that, but this particular version, called keratoconus, is an inferior or lower part of the cornea bulging. And you can see these red spots that are forming at the bottom of the cornea, and you can kind of think of that as the cornea pointing in the direction of those red zones. And what should be happening, of course, is the cornea should have a central zone that is typically flatter, and then there'll be steeping as you move towards the center, but these will be symmetrical. And in keratoconus, a particular version of ectasia, you see this inferior version. We have a clinic in Lombard, Illinois, and we are the first center in the Chicagoland area to offer the first FDA-approved version of a system that is able to stop this condition called keratoconus and really most ectasias. And as you'll hear as we move further into the talk, we believe that we're actually going to be able to rehabilitate vision and get patients perhaps for a dramatically reduced need for contacts and glasses. And fine. Keratoconus is a bilateral progressive corneal ectasia resulting in this irregular astigmatism or loss of visual function. Irregular astigmatism means that unlike normal astigmatism, where there is an axial line that can be drawn across the eye, where the eye is either steeper or flatter, in a patient who has irregular astigmatism, the astigmatism as it flows across the cornea will suddenly take an angle that is not in a 90-degree angle to the opposite axis. So in other words, the patient has a part of their cornea that is heading off in a direction that is not symmetrical to the other side of the cornea. Irregular astigmatism has many bad qualities to it, but one of the primary bad qualities of it are that it's more difficult to correct. Glasses do not correct this well. And so to get a patient of best corrected vision, we are going to have to give them a contact lens, a hard contact lens. And as the condition progresses, even contact lenses become increasingly inefficient. And oftentimes in the past, patients would move on to having a corneal transplant. This condition of keratoconus affects about 1 in 2,000 people, which sounds like a small number, but in fact, in a population the size of Chicago, there's a fairly large number of people that walk around with either the full clinical condition or a partial condition that is progressing. The tradition of this treatment, of this condition, did not show a strong predilection for genetic inheritance. There is associations. A large association with this particular problem is eye rubbing, and it's often been suggested that eye rubbing is the cause of keratoconus. In fact, it's not clear whether eye rubbing is in fact the cause or is more an effect of the disease, that in fact the patient simply gets a tremendous relief by rubbing their eyes in terms of the feeling or itching or discomfort they have from having these kind of corneas. In the past, the rigid specialty contact lenses were the primary treatment for patients with keratoconus. These would help stabilize to some degree, but would not typically arrest the progression of the disease. Intact intracorneal ring segments came along in the 1990s. They were initially thought to be successful for the treatment of small degrees of myopia, but since laser vision correction was so successful, instead we began to use these as a support structure for the inferior part of the cornea. So these are inserted around the pupil, and in doing so, it provides a kind of an internal support to the cornea, which can perhaps help slow the progression of keratoconus, and in some cases can actually push the center part of the cornea up, which can improve the curvature over the center of the eye, and in doing so, improve the vision. In patients that progress dramatically, the cornea would thin to the extent that we would be forced to perform a corneal transplant. And corneal transplants in a patient with keratoconus were smaller transplants. You would take a smaller amount of central tissue to replace, and they had a fair degree of success in terms of not rejecting. We're still getting donor tissue, and the vision one would have after a corneal transplant would be often would have a lot of aberration, that is to say, a lot of glare, and it was often difficult to get your vision back to the degree of clarity that would be as gratifying as most people would like to require. It would often lead to some degree of disability. And so, which brings us to the discussion of what we're doing today. This is this transdermal or rapid corneal cross-linking. I'm just mentioning here that about 73% of grafts fail after 20 years, 98% after 30 years. So the potential for retransplanting was often a significant problem. As you can see, about 1,600 transplants a year for keratoconus, which would include, of course, the retransplants. And Thiel Seiler, a friend of mine over in Switzerland, had this idea back in the early 90s, or late 90s, for placing riboflavin onto the cornea as a kind of a reactant that he would then use by exposing the eye to ultraviolet light to create what are called free radicals, or singlet oxygen molecules inside the cornea. And when you do that, these free radicals would cause a reaction in the layers of the cornea. And this reacted cornea would then so-called cross-link. That is to say, the tissue layers, which can slide against each other, would be arrested in terms of their ability to slide against one another. And the first group of patients that were treated in 2003 have all been followed out to the current time, and none of these patients have progressed in their condition. Some of the patients saw a mild flattening of the central cornea. The cornea typically is very steep centrally, and an improvement in vision, but most of these patients simply had an arrest in the progression of their disease. We can't let this disease go too far beyond a certain amount of thinning. The effectiveness of the treatment is decreased. So treating this early is a very important concept. Recent work has shown that with the full treatment that we can give with this particular device and the FDA-approved treatment, which is called the Dresden protocol, that we can possibly use excimer treatment to improve the vision before we start the corneal cross-linking. So in other words, we're going to remove a small amount of tissue off the front of your cornea to reshape the front of your cornea to allow us to move on to then cross-linking that shape onto your eye. And in those patients, we've not seen any further progression. The first sites, of course, were done in Dresden. As I mentioned, the corneal collagen cross-linking medical procedure that combines the use of ultraviolet light and riboflavin is what we're talking about here. this procedure involves putting drops of riboflavin, sort of soaking your cornea in riboflavin, and then exposing your eye for short periods of time to a wavelength of ultraviolet light that would be similar to what you might use for a tanning booth. The device looks like this. It's simply a lamp, and the riboflavin is like a vitamin. It looks has a kind of an orangish appearance. We have a viscous version, and this is used when your cornea has become so thin we need to thicken the cornea a little bit to protect the inner lining of the cornea, which is called endothelium. We like the cornea to be at least 400 microns in thickness, and to achieve that, we can cause thickening of the cornea using these protective viscous. There have been work done in Europe to try to come up with formulas to allow this treatment to be performed without taking off the anterior surface of the cornea. The standard technique is to remove the epithelium. When we do this, we find we get a very deep treatment. And in several studies that have looked at try to compare the so-called epi-on versus epi-off treatment, we have found that the epi-on treatment is much more effective. So we take a 9 millimeter zone off the central part of your cornea. We give you a drop of this riboflavin drop every 2 minutes for 30 minutes. We check to see that there's a bit of riboflavin in the anterior chamber that we can look into with a lamp into your eye, and we can see if there's a bit of flare, a bit of this vitamin inside your eye. At this point, we check the thickness, and at this point, then we can begin using the ultraviolet light. There's a specific wavelength that has been found to be the most effective for getting the most reaction in the shortest period of time. And this is the 3 milliwatt method. Also, significant amounts of studies have been done to show that this, at this particular level of treatment, that we get a safe treatment. We don't cause any injury to your cornea. So the postoperative care for this, mostly we're talking as if this is PRK. So PRK, of course, was photorefractive keratectomy, and this procedure is the procedure we'll perform where we do laser vision correction without making a flap. And so photorefractive keratectomy care is exactly the same care we'll see with our patients that have had cross-linking. There may be a slight bit of increased discomfort, though this can be limited with our modern techniques. We use a bandage contact lens, so that when you're blinking after the procedure, you won't be blinking over the zone that's healing. We normally expect to see an initial steepening. In other words, the cornea will get a little bit worse right after the treatment, and then it will slowly then begin to flatten. Contact lens refitting is a standard that is often applied to patients that have this because they're not getting a change actually in their corneal curvature by this treatment alone. The treatment is only going to arrest the progression of your disease. The expectations of corneal cross-linking itself is it's not necessarily a refractive procedure. And it's our expectation, though, that we really have no reason not to perform a PRK-like treatment to reduce your astigmatism. We believe this is going to be the routine treatment that we're going to be providing at the Foulkes Vision Institute. The efficiency and safety is now accepted. The ideal excimer is a topographic laser, and we have these lasers available in the United States. But even when the astigmatism that you have is addressed alone, your vision should improve. And so this is very exciting because we really have had no way to provide this for you in the past. And it would appear with this epithelium-off, epi-off treatment, that we will be able to provide this. This simply can't be done with epi-on treatments. Epi-on treatments simply are not as deep, and the safety of doing that would simply not be there. Furthermore, without removing the epithelium, you cannot change the shape of the cornea. So again, it will be your expectation that if it's possible at the Foulkes Vision Institute, we're going to be changing the shape of your cornea to allow you to improve your vision once you've been through this treatment. The timing of additional treatments is debated, and we would discuss this with you at the time of your surgery. Currently, we'll review each case, and it may well be possible that we can perform an insertion of the intact ring as well as corneal reshaping. And so this is a very exciting possibility, and depending on the degree of your keratoconus and depending on your particular needs, the intact rings are inserted. We do have the laser required to perform this procedure, and we performed many of these procedures here in the Chicagoland area. You don't want to rub your eyes after this treatment, obviously. Patients will be sensitive to light, of course, and you'll have a foreign body sensation. It's really variable, the discomfort, and again, we have developed methods to reduce this discomfort. It certainly will not be more than a few days. You're generally advised to take a long weekend, essentially, to allow yourself to recover. We'll typically have the contact lens removed about 5 days after it's been placed. Since this procedure is essentially a PRK treatment, depending on the level of comfort of the referring physician, we will be more than happy to have them manage your post-operative care. As once the treatment is performed, all that's really left is for you just to heal. The Avedro product protocol is the first and only FDA-approved therapeutic treatment for the progression of keratoconus, or really what we call ectasia. And we're providing the first FDA-approved and co-managed facility to assist in rehabilitation of keratoconus patients. We're finally able to not only arrest this disease, but actually to consider rehabilitating your vision. And for someone who has been practicing since 1993, I can tell you that this is an extremely exciting moment in our understanding and our ability to treat ectasia. Early intervention is key, and the earlier we capture you under this device, the sooner you arrest and can start to get back the vision that will most likely be your vision for the rest of your life. Our clinic uses a premier corneal tool called Galilei, which is what's called a dual Scheinpflug topographer. Scheinpflug is a technique for looking at the corneal dimensions and corneal curvature. And it's a very important tool when you're looking to analyze all the dimensions of your cornea that are going to be required to see, first of all, if you can be safely treated, what degree of treatment could we consider, and also to follow progression if we're going to follow you up the road. Any topographer, however, can generally determine that you have this condition. And the Scheinpflug will simply be used when you come to our clinic to further look at the dimensions of your cornea so that we can further analyze the safety of performing the procedure surgically. My staff has performed dozens of these procedures, and we're experts in reducing discomfort. In fact, one of my staff members has been part of a clinical trial study looking at epithelium off and epithelium on, and found, in fact, that the discomfort factor was approximately the same with both procedures. So some patients may find a little less discomfort with epi on. It also is a discomforting procedure for the first day or two, which again, completely manageable. And with epi off, so the treatment that you're going through may cause some degree of discomfort. one can feel reassured that you've reached the deepest level of treatment possible. And the probability that you might progress in the future has been virtually eliminated. And most importantly, because we're treating deeper, we can, before applying the treatment, apply the excimer laser to cause a small degree of reshaping of your cornea, which can then improve your vision, improve the curvatures, and perhaps improve, worst case, the discomfort and problems you have with contact lenses. And in the best case, may reduce your need for contacts or glasses. So we're extremely excited to offer this procedure, and we would very much like to have the opportunity to discuss this with you further. You can contact my patient coordinator, Joyce Waltner, or call me directly at our clinic in Lombard. The number is 630-924-1400. You can also email us and look for us on the web at glassesfree.com. And we would be extremely excited to get involved with your care. And if you're looking to co-manage with us, this is, again, a discussion you can have with myself or with Joyce. We're extremely excited to offer this as a co-managed treatment because it is very much like PRK. And what we'd really like to do is to get involved with the care of your patient to see that we can not only arrest their condition, but actually improve the overall curvatures of their cornea to get them back to a vision that could allow them to perhaps get back into glasses or have a better fitting contact lens. So please do get in touch with us if you have any questions. I'd be more than willing to address those. And the question that's coming in here is, what is the earliest age that we can provide this treatment? And the answer to that is we certainly would like to see you refer the patient that you believe has keratoconus at the earliest age possible. Normally, we can start to detect the presence of keratoconus by the age of 14. So certainly teenagers are an ideal place to consider getting the referral over to us. Patients can be treated at any age, and certainly we do believe that the rapidly progressive stage of this disease, though, is in younger people. And so if you can get those patients to us sooner, we should be able to have more cornea there as well, or thickness of cornea, so the cornea won't have thinned as much. And this should allow us to open up the possibility that we can provide them with a combined treatment using the excimer laser to reshape the cornea, as well as stop this progressive sliding of the lamellar planes inside the cornea. So be on the lookout for this disease. Be screening patients. If patients are coming to you for contact lenses, especially patients with astigmatism at a young age. Look at them carefully with a topographer. If you see some degree of inferior corneal steepening, please refer them over so we can make the consideration of whether or not this is early keratoconus or so-called Foulkes keratoconus. Question just came through, can this be used for ectasia that is post-excimer ectasia? And the answer is absolutely. We have seen, in fact, the thinking in the future is going to be that we may be using this treatment for thin corneas that would allow us to perhaps treat corneas with excimer ablation that might have been ruled out for treatment in the past. It also may well be the future of corneal cross-linking, that we can actually place a shape on the cornea, kind of mold a shape onto the cornea, and then cross-link that molded shape into place using cross-linking. And that is very interesting, and there are studies actually progressing to look and see if that's going to be a possible way that we can improve vision via this single method. Very exciting work, and we're very excited to be the first center in the Chicagoland area to be providing these kind of direction and leadership. The diagnosis of keratoconus is worthy of another talk, and I will look to post this up in the near future so we can help you with your, just for the current patient that we're looking for. And of course, the earlier we can capture this very early disease, the so-called form crust keratoconus, the better. Modern topographers are especially good at catching this, but we have definitely improved our understanding of how to diagnose keratoconus in the early stages. And if we can help you with this, I would certainly like to do that. So I will post up another talk specifically focused on the diagnosis of form crust keratoconus, or early keratoconus. Once keratoconus becomes, or really any ectasia becomes full-blown, it's quite easy to make the diagnosis when one sees those steep Ks. The Dr. Thiel Seiler in Switzerland is very keen on pointing out that the earlier, the less steep the cornea, the better the result we can get from this. And of course, we can alter those shapes a bit by using the intact corneal rings. And so we can cause some flattening to occur using those rings in conjunction with corneal cross-linking, and now with the use of the excimer. So the future of keratoconus treatment has truly advanced, and we're very excited to be your referral source. Please call us if you have any questions. It would be a privilege for us to work with you and your patient. And we hope that we have turned the page in terms of the care of patients with ectasia in the future. And thank you for tuning in this morning. And again, if you have any questions, if there's anything that we can help you with in terms of understanding the process of treating a patient for corneal cross-linking, please let us know. The device in our clinic is available, and if an ophthalmologist in the Chicagoland area has a patient they would like to bring in, we can walk them through how this treatment works. And so you can please contact me if you have some interest in that as well. We can provide guidance and help you remove your patients and freeze the development of this progressive condition of ectasia. So thank you again for tuning in this morning, and I certainly hope that this has been helpful. It is really an exciting era, and we're very much, as you can hear, excited to get involved to help you with your patients and to help patients so that they can avoid the terrible progression that this disease can cause. So thank you again for tuning in, and we hope that we can be of assistance to you with your patients in the future. And again, this is Dr. Richard Foulkes. Call me if you have any issues, or if you'd like to email me, feel free to do so. George can give you my email. So thank you so much for tuning in, and we'll hope that we can be working with you in the near future to assist you with your patients with ectasia. And have a good day.